Prescribing in pregnancy is an important function of a doctor. So whenever you are writing a prescription in a pregnant patient, those prescriptions are different from somebody who is non-pregnant. So as a house officer, as a medical officer in the hospital, or as a family physician, or as a consultant, you may be called upon to write a prescription. You need to know the basic principles which make prescribing in pregnancy different from writing prescriptions in outside pregnancy patients. So let's dive in. So at the end of this lecture, these are the objectives we hope to cover. You will be able to list the reasons for considering why pregnancy is a special situation in prescription of medications, describe the terms pharmacokinetics and pharmacodynamics, list the certain physiological changes which influence the pharmacokinetics and dynamics of drugs, describe the embryogenesis in outline and influence of drugs on each stage and how they affect the development of the fetus. And then we'll talk about the classification of drugs during pregnancy which are available at the moment, and list basic principles of prescribing in common situations encountered in pregnancy, and briefly about some principles about teratology or abnormalities caused by drugs, and some examples of famous situations which have occurred due to errors in prescribing in pregnancy. So what is so special about prescribing in pregnancy? We will cover few concepts which are generally learned well in pharmacology. Pharmacokinetics is the study of time course of drug absorption, distribution, metabolism and excretion. Dynamics is, on the other hand, effects of the drug on the body. Kinetic studies the effect of the body on the drug. Dynamic studies effect of the drug on the body. So it's biochemical, physiological effects of drugs and their mechanisms are the ones which are studied in dynamics of pharmacological agents. Half-life is the time taken to reduce the concentration by half. Steady state is when the drug amount absorbed and drug eliminated reaches equilibrium, and this depends on half-life. Generally, we know that it takes about 5 half-lives to reach a steady state level concentration in most of the drugs, and this the steady state concentration is directly proportional to the size of the dose as well as the volume of distribution. Clearance of a drug is the unit of volume of plasma which is cleared of drug in a given time, say generally milliliters per minute. Then we have effects which happens which are due to breakdown of drugs in the body when they pass through certain organs like liver, lungs, gut, mucosa or kidney. So any drug which passes through an organ which is metabolizing them will affect the distribution and the concentrations. So certain drugs which are metabolized in liver like pethidine, lidocaine and estrogens will affect the final concentration of those drugs. And then drugs which are metabolized in the gut mucosa like ethanol, levodopa, chlorpromazine again affects their distribution. Drugs which are metabolized in lung like isoprenylene will be of reduced concentration after one pass through the lung. And then we have another term called bioavailability. So certain drugs get absorbed and then they are modified in the body usually after first pass metabolism in the liver or in the kidney, and then become bioavailable. So if the liver function or renal function is low and the available drug concentration is probably going to be low. Depends on this bioavailability depends on the formulation, disease status, first pass effect, as well as the gut motility. So whenever you are prescribing drugs which are absorbed primarily from the gut, if the gut movement is slow, like in pregnancy, then it might have reduced effects. The volume distribution is the volume which is taken up by the drug after this absorption. So drugs which are highly lipophilic, like most of the anesthetic agents, will have large volume of distribution because of the availability of large amount of fat in our body. Certain drugs which are distributed only in water soluble areas will have reduced amount of volume of distribution. And then when drugs are eliminated, there are two types of elimination. One is first order elimination, which is a linear elimination. The rate of reaction is proportional to the amount of drugs available. So it usually follows a proportional distribution. Zero order elimination is that the process proceeds at a constant rate independent of the amount of drug available. So this is first order and this is zero order. So whatever the concentration, amount of elimination is single. Then so we'll talk about the things which happens in pregnancy now. In pregnancy, due to various physiological changes like increasing in plasma volume, increasing in cardiac output, increasing in renal blood flow and glomerular filtration rate, and induction of liver enzyme pathways, there's a reduction in plasma protein content, and it will reduce a delay in cause a delay in gastric emptying. And that results in changes of pharmacokinetics. It will increase the volume of distribution, reduce the plasma concentration. It increases excretion of renal products, and it increases the hepatic metabolism. So these are the changes which happens due to those physiological changes in our body, and effectively that will affect the amount of drugs which are there in the circulation and its effects on the mother and the fetus. Then certain drugs, instead of remaining only in the maternal circulation, will cross. So generally drugs which cross the placenta under normal circumstances will distribute equally among the mother and the baby. Good example is alcohol. If the mother is taking alcohol, since alcohol easily crosses to the placenta, same concentrations are experienced by the baby. So if a mother is intoxicated, baby too is intoxicated. Certain drugs which are limited only to maternal circulation because they cannot pass through the placenta, like heparin, because of its high molecular weight, or due to polarity, due to electrical charges, will not cross and will not be seen in the baby. And certain drugs which are metabolized by the placenta will not be there in the baby, like prednisolone. Prednisolone, though it is a steroid, it gets metabolized by the placental sulfatases in the placenta. Because of that, they will not appear on the fetal side and is safe in pregnancy. Then we come to a related term called teratology, which is the study of monsters, and these abnormalities occur due to a teratogenic agents. Teratogen is an agent that causes physical or developmental abnormalities by preventing the developing embryo or fetus reaching its full genetic potential. A drug can have its teratogenic effect or risk of causing abnormalities due to the dose which we use, due to the exposure time when it is exposed to the baby, fetus. If the fetus is exposed to a drug at the beginning of the pregnancy, before implantation or immediately after implantation, during the embryogenesis or during the fetal life, its effect on the fetus or the developing tissues of the fetus is different. Effects are maximal when it happens during the embryogenesis. Effects are less when it's available or the drug is administered towards the latter part of the fetal life when majority of organ systems are developed. Each organ system responds to certain drugs in different way. Some will not tolerate, some will tolerate and adapt. So the changes or damages due to the drug depends on the organ system and the time of exposure. And again, it depends on the bioavailability of the drug. Certain drugs, though they are potentially toxic, will not be biologically available because of the degradation or whatever. And certain drugs will have active metabolites after the degradation in the liver or in the kidney. Then again, those drugs can have effects like most of the narcotic drugs. Their breakdown products again will have certain biological activity. Benzodiazepines, their breakdown products again will be active. So they will have effects on the fetus even if the main drug is not there. And certain drugs will interact inside the body. So if you are putting the patient on multiple drugs, that again is going to cause issues to the fetus. And another thing which you need to remember is that drugs which are prescribed in pregnancy are given without any knowledge of the woman that she is pregnant. As majority, almost 70% of pregnancies are unexpected. Even in planned pregnancies, we do not detect them until around 8 to 10 weeks of gestation. By that time, which is the period of embryogenesis, most of the drug has happened and the baby has been exposed. And certain vitamin supplements, people take it as over-the-counter medications. And don't forget about all these native medications or Ayurvedic preparations people take for making their skin fairer or to hair grow, whatever. They also are chemically active. So it's not only the allopathic medicinal drugs, any drug, anything which the patient takes, even the food in excess can cause problems with the fetal development. One good example is the lesson we learnt from thalidomide. Thalidomide caused babies to appear like this, with no limbs and short limbs or absent limbs and no hands. So a drug which is produced by a company called Ciba-Geigy in 1950s, and then another tech company took over, shown to have sedative properties and shown to be very effective for nausea and morning sickness in pregnancy. So it was marketed as drug of choice in pregnant women from about 1957. And it was branded as Contragan. Almost everywhere it was used. And by 56, 57, some people have noted that the babies are affected. But until somebody in Australia in 1961 wrote a letter to Lancet mentioning rare limb ear defects in large numbers, and majority of those mothers were given this drug to treat their nausea and vomiting. So by another year, the drug was withdrawn, and it ended up with 10,000 affected babies worldwide, and majority, around 40% of them, died before their first birthday. So how do we know whether the drug is teratogenic? It's very difficult to confirm. The best way is to do a double-blind control trials in humans, but we cannot do them because of obvious ethical, medical, legal reasons. So we have to rely on case reports, epidemiological studies like surveys, or laboratory experiments using other animals. So most of the drugs will, during their licensing process, will pass through cell line testing, tissue culture models, in vitro embryo culture models like rat embryos or other pregnant mammalian mammals are used. Sheep, pigs can be used. But laboratory experiments are limited. They may not be very successful because some drugs are tested at a higher dose in humans, whereas it cannot be given in the same dose to a small animal. And the time of exposure, what is whether the animal model which we use to test the drug or the tissue culture model which we use to test the drug is similar to that in the humans. Those are difficult questions to answer, difficult questions to validate. So it's very difficult to confirm or refute whether a drug is teratogenic. Whether we can find any evidence of toxic effects on the embryo while the drug is being developed is difficult. And each species handle drugs in different ways because their metabolic systems are different. So using animal models or other systems is always having various multiple loopholes which can make most of the new drugs unsafe, like in the case of thalidomide. So this brings us to the embryologic states in our body where we have different sensitivities to drugs. Now this chart shows the developmental ages in weeks and various effects of drugs at various levels. We know that in the first 3 weeks of the pregnancy, the embryo implants in the decidua or the endometrium. If any drug is given usually at that time, if it is really toxic, it will result in embryo death. From 3rd week to until about 14-16 weeks, most of these drugs, this is the embryogenic period, up to 8 weeks, 9 weeks. During that period, these drugs will have isolated effects on various systems like neural tube defects due to various anti-epileptic drugs or various drugs on heart, or depending on the limbs, cleft lips, ear defects, eye defects, and then towards the latter part of that period, around 7-8 weeks, they will have effects on the cleft palates and the dental defects or the enamel defects. And even later, around 9, 10, 11 weeks, because that is the time when the genital systems are developed, certain drugs like male hormones or androgenic estrogens or progestogens can have effect on genital development of the female, causing masculinization or virilization of a female fetus. So you can see that each organ, as it develops, changes its sensitivity. So CNS is mostly sensitive during its initial stages of the embryonic life, around 3rd to 6th, 7th week. And later on, exposure on these systems will not really cause major malformations, but will probably have effects on the function, like mental retardation. Same with others. Around 6 weeks is the time period where you have the heart development, and so any exposure during that period, if the drug is toxic to that tissue part, it will have. So major anomalies or congenital anomalies occur due to drug exposure during this period. And then later in the life, from after 16 weeks until the birth, most of these drugs will have their effects on the functional aspect, will not cause major structural abnormality. So thalidomide caused, since it was given around the time of 6 to around 14 weeks, 16 weeks, they caused these abnormalities in the limbs, like amelia, no limbs, micromelia, short limbs, cardiac effects, hemangiomas, urinary tract effects, as well as digestive tract defects. So this brings us to the types of drugs which we are allowed to use in pregnancy. So American Federal Drug Administration classified drugs. It probably came from 1960s after the Thalidomide disaster. They categorized drugs into 5 categories called A, B, C, D and X. This was used until recently, but from 1915 onwards they changed that. This classification again had certain imperfections. So what we are using now is called the Pregnancy and Lactation Laboring Rule, PLLR, and this has removed the ABCDX categorization. We were not supposed to use this X category because they were unsafe in pregnancy. So the current labeling has 3 main categories: 8.1, 8.2 and 8.3. So 8.1 drugs are drugs which are shown to be safe during pregnancy. Drugs which are safe during lactation are colored in this color, turquoise, and are referentially labeled. And then another group of drugs which are safe in females and males of reproductive potential, because certain drugs, even though they are not tested in pregnancy, may be used in people who are awaiting a pregnancy. So that is very helpful when you are prescribing in younger population who are probably exposed to the risk of a pregnancy, but they are still not pregnant. You need to use drugs of this with this label. So it's only 3 labels, and they advocate using them. Now we have drugs which this is a list of common medicinal products which have proven embryological effects. Right? Alcohol causing fetal alcohol syndrome, androgens causing masculinization, benzodiazepine causing floppy infants, antimetabolite drugs like methotrexate causing multiple malformations, carbamazepine, which is a common anti-epileptic, causes spina bifida and multiple fetal cardiac and other malformations, cocaine, a drug of abuse causing CNS effects as well as other intestinal and kidney damages, warfarin and other coumarin anticoagulants causing coumarin syndrome, iodine overdose causing hypothyroidism, lead causing various congenital mental retardations, misoprostol causing a certain characteristic Mobius sequence like problems with the limbs. Limbs are smaller and appear like cut with the scissor, or limb reduction defects. They are common with misoprostol, so it's not a 100% safe drug. Penicillamine causing very tough skin or lax skin, and phenobarbital causing multiple malformations, phenytoin causing again neural tube and cardiac malformation, facial malformations, retinoid, vitamin A derivatives causing ear, CNS, cardiovascular and skeletal disorders. So retinoids, vitamin A preparations for acne and other things are off, should not be used for women who are expecting to be pregnant or who are pregnant. Tetracyclines causing discolorations, valproic acid causing spina bifida, vitamin A more than 25,000, again same effects as other retinoids. And now we'll go into a few drug classes of certain importance like anticonvulsants. So phenytoin can cause, if you are using them, craniofacial abnormalities, hypoplasia of the distal phalanges, growth deficiencies, mental deficiencies. Valproate is associated with neural tube defects, facial defects. Carbamazepine is again like phenytoin, but generally considered as having a decreased risk compared to others. So generally it is considered as a drug of choice with regard to antiepileptics. All these drugs affects their effect through on the closure of neural tube from around 2nd week to 3rd week of pregnancy. and will result in spina bifida at various levels. It can be spina bifida occulta, spina bifida with meningomyelocele, spina bifida with only meningoceles, or spina with myelochysis largest. Right. So it can cause various problems in the baby, and in the worst case, it can cause hydranencephaly or anencephaly. And then phenytoin and other drugs can cause problems with the fusion of facial bones, leading to cleft lips and cleft palates. Most of the phenylbarbitons, retinoids, methotrexate, and valproates can cause these defects. And you can see this is a cleft palate in the soft palate area. This is a cleft palate in the hard palate as well as the lip. This is a tetracycline discolored teeth, usually exposure of the mother around 14 weeks to 10 months of the pregnancy. They are called because it affects the primary teeth. And later it's called, when it is coming to the permanent teeth, again it can cause this. So you have to be very careful in prescribing tetracycline in children as well as mothers. Genital tubercles are affected from around 8 to 10 weeks of pregnancy. And usually when you are prescribing drugs like noitesterone, which is androgenic progesterone, because it's derived from testosterone, it can cause masculinization of a female fetus. So any woman who is at risk of having a pregnancy inside should not be given these drugs, because we use it commonly to induce the withdrawal bleed, and you will be tempted to use it. But if they are at a risk, higher risk of getting pregnant, better not to use noitesterone, use some other progestogen. Fetal alcohol syndrome is another common example for effects of drugs. You can have thin lips, flat nasal bridge, short noses, microcephaly, mental retardation, cardiac defects, joint defects, and baby himself will look like a drunkard. This is congenital goiter. It can be there when you use carbimazole or propylthiouracil in pregnancy to treat mothers with Graves' disease or hypothyroidism. So you need to be very careful and you adjust the dose carefully. And when you are looking after the pregnancy, always we need to scan for any fetal goiter in the fetus itself while in utero. Drugs which we are using to induce labor, stop labor, again can have effects on the fetus, but they are generally mild. But drugs which we use to stop labor, the pregnancies from progressing, mifepristone and misoprostol, can, if they are unsuccessful in terminating pregnancy, can cause various major cardiac and limb defects of the fetus. Drugs which we are using to treat or stop coagulation are teratogenic, especially the drugs like warfarin. So we generally don't use warfarin in the first trimester when the organogenesis occurs, because it can cause problems in the cardiac, cartilage, optic atrophy, and mental retardation. This is called Coumarin syndrome or warfarin embryopathy. And it is safer to use heparins because they don't corrode the placenta and are not causing exposure to the fetus. All cytotoxic drugs, whether it is antimetabolites or alkylating agents or vinca-alkalides, since their effects are mainly on the cell cycle at various stages, are teratogenic or even can cause the death of the fetus. And actually we use methotrexate, anti-metabolite, to kill off ectopic pregnancies because of its effect on developing fetus. Now we come to the lactation, and any drug which is prescribed depends on its effect on the baby, on its ability to pass through the milk. So some drugs, though they are present in the maternal circulation, will not be transported to the milk. And the drug ability to influence the passage into the milk depends on the characteristics of the drug, route of administration, whether it is given IV or oral, absorption rate of the drug from the gut, half-life or peak serum time, and dissociation of the drug in the mother system, and volume of distribution. And also the ability of mother to metabolize or excrete the drug. Generally, drugs which are more water soluble or lipid soluble tends to go into easily to the milk. And drugs' effect on the fetus depends on infant's ability to absorb, detoxify from the liver or kidney, and excrete the agent. And all these things are dependent on the maturity or the age of the fetus. So drug comes in through the gut, lung, skin, IVM or IV, absorbed, get into the mother's bloodstream, distributed to all the areas of the body, and then store or excrete. This is what the normal pathway. So in pregnancy, they can come into the breast, get excreted, and generally drugs which are highly lipid soluble will pass, but highly protein bound drugs in the maternal serum will not be passed. Drugs which are small molecular weight will pass easily. Drugs which are acids, weak acid, weak bases will have equilibrium level. Drugs which are actively transported will be passed preferably into the fetus. So those are the drugs which we have to be very careful. And various ways are described, like diffusion, carrier-mediated diffusion, actively transported, pinocytosis or reverse pinocytosis, so this way or that way. So I am not going into detail, but you would have learned them in your histology or the anatomy lectures. And then each infant or the fetus have different ways of handling its maturity, and its ability to absorb, metabolize, and excrete depends on the maturity. And whether it is given by the gut or IV, again, changes its effects on the baby. Drugs which are dependent on the kidney and the liver for metabolism can cause major side effects because infant's liver or the fetus's liver is immature. Like aspirin. If you are giving aspirin to the infant, that can cause hyperbilirubinemia because aspirin will compete with bilirubin to binding into albumin, and that will release bilirubin into the circulation at a higher level and cause jaundice. Theophylline, which again can be used in fetus, but it's dependent on kidney to excretion. Since infants' kidneys are not mature, they get accumulated, and that can cause toxic effects on the fetus due to theophylline. So we describe a concept called milk to plasma ratio. That is the amount of drug which is there in the maternal milk versus the amount in plasma. Drugs like atenolol, you see that its milk to plasma ratio is 3, so the relative drug dose is around 8. And captopril, milk to plasma ratio is low, whereas iodine, milk to plasma ratio is higher. Carbimazole, valproic acid, lithium, relative drug dose is higher in the fetus. So drugs which are excreted in breast milk should be avoided as much as possible. That is the final message about lactation. Like antibiotics like aminoglycosides, sulfonamides, tetracyclines, metronidazole, chloramphenicol should be avoided. Chloramphenicol has an effect on the fetus which is called the grey baby syndrome. So you will need to, when you are learning about these antibiotics, learn their effects on the fetuses separately. I'm not going to go into detail. Anti-TB drugs like isoniazid, narcotic analgesics, morphine, pethidine, benzodiazepines, chlorpromazine, carbamazole, phenytoins, phenobarbitons, carbamazepine, warfarines, and other cytotoxic drugs. They are all excreted in breast milk and can cause problems. And these drugs can have, some drugs can have effects on the endocrine system of the baby as well as in the mother. So, methyl dopa like drugs can cause galactorrhea. Certain tricyclic antidepressant, maxalone or metoclopramide, cimetidine, benzodiazepines can cause galactorrhea when you are using it in any woman. So, they can mimic symptoms of pregnancy. Some drugs like spironolactone, cimetidine can cause gynecomastia even in males. Drugs which are used like lithium and amiodarone can cause hypothyroidism. Diethylstilbestrol like drugs which we no longer use can cause vaginal carcinoma because of its effect. Now we need to learn a little bit about the vaccinations in pregnancy. Like there are certain drugs, vaccines which can be used and some which cannot be used. Now, live attenuated vaccines are generally not used in pregnancy. Other drugs can be, say, influenza vaccines, DTP can be used. HPV, since it's live attenuated vaccine, MMR again live attenuated, varicella vaccine live attenuated, they are generally not recommended to be used. Hepatitis A, B, Hep, meningococcal, these are capsule based vaccines, they are not active organisms, so can be used or may be used depending on the recipient. So this brings us to the summary or the main principles of prescribing in pregnancy. If you remember only one slide in this lecture, this is it. You should prescribe a drug only if the clear indications are there for benefit to the mother, whether if that outweighs the potential risk to the fetus. That is the only indication for you to prescribe or write a prescription to a drug in pregnancy. Wherever possible, try to and avoid all drugs in the first trimester if it is possible. Medication should be used in a smallest effective dose. So if you are using massive doses to get a good effect, reduce the dose and use it for the shortest required duration in pregnancy. Don't go prescribe continuously. Prescribe medication that has been widely used in pregnancy, so has a good safety record. Because of that, all drugs should be preferred. Now, classic example is methyl dopa. Hardly anyone in adult medicine area will be prescribing methyl dopa for hypertension control. It had been used in 1950s and now nobody except us in pregnancy use it. Because it's not a very effective drug. It has major side effects, multiple side effects, and it's not a very effective control of hypertension. But in pregnancy, it has been used from 30, 40, almost half a century. We know that it is safe and doesn't have major side effects with regard to the fetus. So because of that, we still prefer to use it. Probably only obstetricians use it for hypertension control. Other drugs with low molecular weights, less than 1,500 daltons, should be, because they can cross placenta, can cause effects on the baby. So smaller drugs, newer drugs, better to avoid. Encourage all patients who are on long-term medications to go through a pre-conceptual counseling prior to going for pregnancy. So your anti-epileptic dependent patients who are on various antihypertensives like ACE inhibitors should actually have a review meeting with their physicians and the obstetricians prior to planning a pregnancy. So that is a practice which most of us doctors don't do properly. So you are kind of responsible if those women end up with abnormal babies because we have not taken the proper effect of counseling them or advising them to go for counseling prior to going for pregnancy. These are some of the resources which you can use to learn more, or in case if you are a family practitioner, you can use them to get information like Teratology Information Services, Epidemiology of Minnesota, Sri Lanka, American College of Obstetricians, and this European Network of Teratology Information will give you a good detailed information about most of the drugs which we are used. Right. Thank you. If there are any queries, you can raise them on the comments.